Hi! Today we are going to discuss the subdivisions and content of the thoracic cavity, paying particular attention to the pericardium and heart. The thoracic cavity is divided into three compartments: the right and left pulmonary cavities, which contain the lungs and pleura, and located between them the mediastinum, which contains essentially all the other thoracic structures, such as the heart, the thoracic parts of the great vessels, thoracic part of the trachea, esophagus, thymus, and components of the lymphatic system. Mediastinum extends vertically from the superior thoracic aperture to the diaphragm, and anteroposteriorly from the sternum to the thoracic vertebral bodies. Each pulmonary cavity, right and left, is lined by a pleural membrane that also reflects onto and covers the external surface of the lungs, occupying the cavities. To visualize the relationship of the pleura and lungs, push your fist into an under-inflated balloon. The inner part of the balloon wall, adjacent to your fist, is comparable to the visceral pleural. The remaining outer wall of the balloon represents the parietal pleura. The cavity between these two layers of the balloon is analogous to the pleural cavity, and the pleural cavity doesn't have any air in it normally, but it has a thin film of fluid. At your wrist that represents the root of the lung, the inner and outer walls of the balloon are continuous, as are the visceral and parietal pleura, and together they form the pleural sac. The heart rests between the pleural cavities and is enveloped by a protective fibrous sac referred to as pericardium. This sac is composed of two layers, a fibrous and the serous ones. The fibrous pericardium is outermost, thick and opaque layer. It encases the heart as well as the great vessels as they exit the heart. The fibrous pericardium is continuous superiorly with the tunica adventitia of the great vessels entering and leaving the heart, and with the pretracheal layer of the deep cervical fascia. It is attached anteriorly to the posterior surface of the sternum by sternopericardial ligaments, which are highly variable in their development, and it is bound posteriorly by some amount of loose connective tissue to structures in the posterior mediastinum. Inferiorly, it fuses with the central tendon of the diaphragm, so the heart is relatively well tethered in the place inside of this fibrous sac. The fibrous pericardium is rigid and it protects the heart against sudden overfilling from the great vessels that piece it superiorly. The inner surface of the fibrous pericardium is lined by a layer of serous pericardium as well as the surface of the heart. Analogous to the layers of the pleura, which is discussed, the layer of serous pericardium adheres to the inner surface of the fibrous pericardium and is called the parietal one, while the one lining the surface of the heart is the visceral layer. At the great vessels, the parietal layer separates from the fibrous pericardium and continues with the visceral layer on the surface of the heart. The visceral layer of serous pericardium forms the epicardium, the outermost of three layers of the heart wall. Coronary vasculature courses between the myocardium and the visceral layer of serous pericardium, between the first and second layers of the heart. The pericardial cavity is a potential space between the parietal and visceral layers of serous pericardium, and normally we have just a few millimeters of pericardial fluid here. This fluid limits surface tension between these two layers during the cardiac cycle. Now, let's explore the anatomical relations of the fibrous pericardium. Anterior to it, we have the sternum, costal cartilages, and anterior ends of the 3rd to 5th ribs on the left side. Posteriorly, we have the principal bronchi, esophagus, descending aorta, and posterior mediastinal surfaces of the lungs. Laterally, the pericardium is in contact with the mediastinal parietal pleura. The phrenic nerves and vessels run between them, between the pericardium and the mediastinal pleura. And inferiorly, of course, the pericardium is related to the diaphragm. If we cut the pericardium open and remove the heart, you will see that the posterior wall of the pericardium is complicated by numerous vessels entering and leaving the heart. The lines of reflection between the visceral and parietal pericardium, between these vessels, form two pericardial sinuses, the transverse and oblique ones. The transverse pericardial sinus lies anterior to the superior vena cava and posterior to the ascending aorta and pulmonary trunk between these vessels. The transverse pericardial sinus has its application in surgery. After the pericardial sac is opened anteriorly, a finger may pass through the transverse pericardial sinus posterior to the ascending aorta and pulmonary trunk. By passing a surgical clamp or ligature around these large vessels and inserting the tubes on a coronary bypass, and then, of course, tighten the ligature, surgeons can stop or divert the circulation of blood in these arteries while performing cardiac surgery, such as coronary artery bypass grafting, for example. The second, oblique pericardial sinus, lies posterior to the heart in the pericardial sac. On the right side, the oblique sinus is bounded by the lines of reflection of the serous pericardium onto the inferior vena cava and the right pulmonary veins. And on the left, the sinus is bounded only by the lines of the reflection of serous pericardium onto the left pulmonary veins. After ascending through the diaphragm, the entire thoracic part of the inferior vena cava, it's approximately 2 cm length, is enclosed by the pericardium. Consequently, the pericardial sac must be opened to expose this terminal part of the inferior vena cava. The same is true for the terminal part of the superior vena cava, which is partly inside and partly outside of the pericardial sac. The arterial supply of the pericardium is mainly from a slender branch of the internal thoracic artery, the pericardiaco-phrenic artery, that is often accompanies or at least parallels the phrenic nerve to the diaphragm. Smaller contributions of blood come from the muscular phrenic artery, a terminal branch of the internal thoracic artery. Bronchial, esophageal, and superior phrenic arteries, branches of the thoracic aorta, contribute to the blood supply as well. And coronary arteries, they also supply some part of the pericardium, but exactly the serous pericardium which makes the endocarp. The venous drainage of the pericardium is from the pericardiaco-phrenic veins, the tributaries of the brachiocephalic veins, and variable tributaries of the azygous venous system. The nerve supply of the pericardium is from the phrenic nerves, C3, C5, primary source of the sensory fibers. Pain sensations conveyed by these nerves are commonly referred to the skin, C3, C5 dermatomes of the ipsilateral supraclavicular region, top of the shoulder, on the same side. The role of the vagus nerve in innervation of the pericardium is uncertain. But sympathetic trunks, they also send some branches here and they control the diameter of the vessels. The sympathetic fibers are vasomotor. Inflammation of the pericardium is called pericarditis. This condition typically causes chest pain that spreads to the back. The pain is worsened by lying flat. Pericarditis is usually a short-lived condition that can be successfully treated with medication. In some cases, pericarditis can become a long-term condition, causing scarring of the pericardium, which restricts the heart's movements. This condition is known as constrictive pericarditis. Constrictive pericarditis is sometimes treated by surgically removing the pericardium in the procedure, and procedure is called the pericardiectomy. Some inflammatory diseases produce pericardial effusion, passage of fluid from pericardial capillaries into the pericardial cavity, or an accumulation of pus. As a result, the heart becomes compressed, unable to expand and fill fully, and of course becomes ineffective. Non-inflammatory pericardial effusions often occur with congestive heart failure. Large effusions or effusions that accumulate rapidly can compress the heart in a condition known as cardiac tamponade, causing breathlessness and potentially fatal low blood pressure. As I previously said, the fibrous pericardium is a tough, inelastic closed sac that contains the heart. The compromised volume of the sac does not allow full expansion of the heart, limiting the amount of blood the heart can receive, which in turn reduces cardiac output. Hemipericardium may result from perforation of a weakened area of the heart muscle due to previous myocardial infarction or heart attack, from bleeding into the pericardial cavity after cardiac operations, or from a stab wound. Pericardiocentesis is indicated as an emergency procedure in patients with cardiac tamponade. Aspiration of the fluid compressing the heart within the pericardial bag may be a life-saving procedure. Bedside sonography can be used to identify the pericardial fluid and other features of the cardiac tamponade. Pericardial fluid and diastolic collapse of the right atrium and ventricle are diagnostic of pericardial tamponade. Well, to perform this procedure, we need to palpate and identify the xiphoid process of the sternum. The point immediately left to the process is used for the administration of the needle in subxiphoid approach. During the emergency, the local anesthesia is not typically used, but if you are in the hospital and you have everything you need around, the layer by layer anesthesia is to be performed. Well, an immediate subxiphoid approach begins just below the xiphoid process. Insert the spinal needle and advance the needle towards the left shoulder under a 30-40 degree angle, aspirating continuously. The internal images presented here show the needle entering the thoracic cavity and perforating the pericardium. If you have an ultrasound available, it is recommended to control the needle movement. Otherwise, you need to stop advancing the needle immediately after it falls through the dense and resistant wall of the pericardium. And withdraw the fluid from the pericardial bag. The pulse and cardiac contractions will improve immediately.